So just starting off with some epidemiology, it's important to keep in mind that these hip fractures constitute about 50% of all hip fractures, and that there's certain risk factors that lead to these things, like increased age, with the average age of these intertrochanteric hip fractures being around 80, which is higher than those of femoral neck fractures. Also, female sex is a risk factor for these injury type. About 500 per 100,000 elderly females um, obtain these injuries compared to 200 for every 100,000 for elderly men. Osteoporosis, history of falls, and then gait abnormalities as well. Things like Parkinson's disease can lead to these injury types. And feel free to interject at any point, Drew, if you want to add anything. But this is just looking at the anatomy here. And what we can see by these horizontal lines is the intertrochanteric region, which goes from about the lesser trochanter up to the greater trochanter, and it overlaps with these vertical lines here. So the intertrochanteric region lies between the greater and lesser trochanter, and since they occur at the proximal femur, we regard this as extracapsular. This is important when we are talking about the vascular blood supply of the femoral head, and the medium circumflex artery, because we know that it's very tenuous, and so fractures to the femoral neck can lead to avascular necrosis. We aren't as concerned about that when we're talking about this intertrochanteric region, and so because that blood supply is preserved, that's something that we focus on. The image on the right as well shows the femoral head and some of the extracapsular region, and then you can see the intracapsular region too.
Yep. One more thing to point out is a common question you'll get is how do you define the subtrochanteric region? And that 5 centimeters distal to the lesser troch is a key one to memorize. So,
Yeah.
and the phrase peritrochanteric, or like an intertroch fracture with extension into subtroch area. Some people really don't like the term peritrochanteric. So, for whatever reason, I feel like, at least in our region of the world, some people like that word, some people don't. So, just describing like intertroch with subtroch extension, or if it's a true subtroch, just leave it subtroch. It's usually one or the other. So,
Great. So here we're looking at some of the insertion sites of the muscles. And the black arrows are showing the muscles and the insertion sites for the greater trochanter, which constitute the gluteus medius, the gluteus minimus, the obturator internus preformis, and the vastus lateralis. The purple arrow shows the lesser trochanter and the insertion site for the iliopsoas muscle. And so this is just relevant muscle anatomy that we should be aware of too when we're talking about this fracture pattern.
yeah, and memorizing these and where they attach is really kind of helpful because you'll see these fragments displace based on what is attached to them. And maybe that seems intuitive, but it's easy to forget. So when you have like a subtroch, you have to remember that all the short external rotators, piriformis, your obturator, and then gemelli and quadratus femoris, they're all working to externally rotate, and then your abductors are abducting, and then your iliopsoas is flexing. So that proximal piece is going to be very displaced compared to your your subtroch or shaft fragment, where the shaft fragment will be adducted from your adductors, um, and kind of off in its own little world, pretty separated from a true subtroch and what the proximal piece is doing. So that's why this slide is important in my mind.
So we're going to break down a little bit more, starting with classifications. Evans classification is one of the classifications that we use for the intertrochanteric fractures, and it's based on post-reduction stability. And so what we really are breaking it down into is it stable or is it unstable? And we'll go through that in the next few slides.
Yeah, the Evans classification. I'm gonna. Sorry to keep disrupting, but I'm just gonna keep
No,
chiming
it's
in.
fine.
I don't think anyone in our area uses the Evans classification.
Okay.
It can be helpful to know just that it exists, along with the OTA classifications. You might get pimped on OTA. It's like a research based classification where some trauma heavy fellowships or programs like to communicate in that OTA classification language. But for the most part, it's uh, sometimes difficult, or more difficult to communicate with OTA classification compared to um, other classification systems that are maybe used more commonly. So there's not like a really perfect classification for intertroch fractures, and Marquisha is going to get into this more, but yeah, wanted to throw that out there.
So stable fractures. The posterior medial cortex is intact, and then there's minimal comminution, and it's able to resist compressive loads. So the stable fracture we will see on the, well, actually I had a slide, but I took it out. We'll see one at the end of the PowerPoint where we can see a stable intertrochanteric fracture, which we compare to our unstable fractures, unless you wanted to add anything to that, Drew.
Nope, that's
And
pretty.
there's four. Hmm.
Yep, that's pretty much the standard thing with stable intertrochs.
Okay. And then for the four unstable fracture types, we have the reverse oblique, any that involve the calcar region, and I'll go into what that is what that's composed of, and then the subtrochanteric extension that Drew brought up earlier, and then those with a thin lateral raw. And so we can see that there is greater involvement of the posterior medial cortex with these unstable fracture types. And because of that, it's going to impact treatment and what we do with these fractures. So this is an image of a reverse oblique, and then to the right of it is the idealized image. These are pretty unstable because there's the medial displacement of the femoral shaft due to the adductors, and it extends from the lateral to the medial cortex, as you can see on the left femur. And so this is what this fracture type would look like.
Yep, and it's named or like reverse obliquity or reverse oblique. It's essentially if you know what the normal looks like as far as stable from the fracture line extending from the greater troch to lesser troch, the reverse is just like an X to that, almost perpendicular.
And so the calcar involvement. The calcar, as you can see here on the left, is a vertical wall density in the posterior medial aspect of the proximal femur. And involvement of the calcar when we have these fracture types can lead to various positioning and shortening of the collapsed fragment. We can also see it here on the right image where it goes in that posterior medial region. And so if we have a fracture that involves this calcar, we would also consider that unstable.
And this one, it took me a while to figure out what people meant by this posterior medial calcar. I'm like, what is this? This is actually a pretty good depiction of it, um, where you have this like really intense column of bone that runs along the posterior aspect of the proximal femur here near the lesser troch. And it's if that's not intact, then you have to be thinking unstable, like we've been saying. But what is interesting is just because there's a fracture of the lesser trochanter, which you can see on the image on the right. Are you able to see my mouse moving?
No, I don't see it, but my screen is also kind of small.
Okay, no worries. But this, if you have just a fracture of like an avulsion of the iliopsoas pulling a portion of your lesser trochanter off, that doesn't necessarily affect the calcar. Does that make sense? So, um, if you just have part of your lesser trochanter fracturing and breaking off, it doesn't mean that it's an automatically unstable intertroch. It has to
Can you
include.
just see that on the X-ray? Is that how you would tell apart between calcar involvement or not?
Yeah, usually you can tell that it's a little bit more of a hefty piece um, in that region of where it's like the base of the lesser troch. And I don't know if because there's scenarios where if you just have an avulsion of your iliopsoas, like breaking off uh, a sliver or just a portion of your lesser troch, that doesn't mean that your proximal femur is unstable because it may not have affected that calcar, which is deeper. It's like the root area of the lesser troch, if that makes sense. So if you're seeing just like an avulsion of your lesser troch and there's not really that calcar involvement, there's other things you need to be thinking about, like certain cancers and certain bone cancers. So it's kind of an important thing to distinguish. Any follow-up questions to that?
No, that makes sense. Thanks.
Yeah. Keep chiming in with the questions. They're helpful.
Yeah, definitely. So this next unstable pattern is the subtrochanteric extension. And so, like was mentioned earlier, the subtrochanteric region is about 5 millimeters beneath the lesser trochanter. So
Sorry,
with extension,
centimeters. Sorry.
centimeters, sorry, excuse me. And so with extension medially, we can see this fracture pattern as well.
Yep. So this is where some people would be like, "Oh, this is a pertroch or peritroch." I think from a student standpoint, you see the fracture line going from the greater troch down, and it's comminuted towards the lesser, towards the calcar region, and then extends distal to the lesser troch. I think it's safe to name these types of fractures as a comminuted intertrochanteric femur fracture with subtroch extension. So that's a pretty safe way to describe this. Oh, sorry. I'm controlling that. Yep.
And then for our last one is the thin lateral wall. And so lateral wall thickness was measured with this blue line. And honestly, Drew, I was like looking, trying to figure out how exactly they did this measurement. And I'm not sure if it's kind of like too out of like the scope of what we're discussing today. But one study I found said that intertrochanteric fractures with a lateral wall thickness less than 20.5 millimeters should not be treated with dynamic hip screw alone. And we're going to talk about more the treatment options for these different fracture patterns. But that's where this can become relevant as well.
Yeah. So the way you measure it, which I don't see people do this commonly, so I think people just kind of eyeball it and say, "Oh yeah, thin lateral wall." But I'd say this is out of the 4 unstable types, maybe the one that's not as obvious to name. But you measure it by starting at your innominate tubercle, and then 3 centimeters distal. That's where that 30 millimeter mark comes in. 3 centimeters distal to that innominate tubercle, and then you go 135 degrees towards your up your femoral neck to the fracture line, and that's what you measure from your lateral cortex to the fracture line at that point. Mm-hmm. So you can see their measurement here headed in that 135 degree. They mark, I think, 130 degree. That measurement is 35.7. So you would be thinking, okay, well, this isn't necessarily a thin lateral wall because it's not less than 20.5 millimeters or 2.5 centimeters. But where that, if it gets, it's that fracture line kind of starts to exit lower and lower and lower to where that lateral wall gets really thin with this measurement. You can't treat those with sliding hip screws because, and you have to be careful with nails as well, because your lag screw or cephalmedullary screw will end up kind of like in that fracture, and your construct will fail. And I think I posted an example of that specifically in our ortho content channel. Maybe someone can dredge that up, where it was someone online or on Twitter posted a case example of like, hey, this is why you shouldn't use sliding hip screws in these types of. It was like either it was some unstable intertroch. So if someone can find that and reshare it, we'll take a look at it after we're done with the talk, just to compare. But so with this fracture that is shown in this image, I would say this has posterior medial calcar involvement in my mind. So you can see that it's not just the tip of the lesser troch, it's more of the root. And there's this fracture line. If you, some people will be able to see my mouse, at least on the recording, where there's this fracture line that includes kind of this whole region, and it's like that root of the lesser trochanter. So I would still call this an unstable intertroch fracture, but because it has posterior medial calcar involvement, not a thin lateral wall.
So now we're going to go into the OTA classifications. And they're broken down into like A1, A2, and A3, with them spanning from 1 to 3 for each one. And so for this first group or class, there's a simple 2-part fracture. And as you can see, the lateral cortex is still intact in all of these. And then the fracture begins to extend over to 2 or more levels of the medial cortex in this next class, but the lateral cortex is still intact. With this final class, you have further extension through the lateral and the medial cortex. So that is one of the differences. So imaging, there's certain imaging that's recommended when someone comes in with this injury type or we're suspicious of it. And so the first one is AP pelvis, and we get this to compare to the contralateral hip. We also want to assess the neck shaft angle, which should be anywhere between 120 and 140 degrees in a person. The next one we'd want to get is a AP of the hip. This just defines the fracture pattern, lets us know if it's a single line break or if there's any comminution. And so we want to get that to assess those things. And then we can also get a cross table lateral, and that helps us to assess for any posterior cortex comminution, which we would be able to see on this view.
So burn this into your brain, guys. This is a hip series. So at least in our institution, maybe it varies elsewhere, but if you're ordering a hip x-ray series, you want a good AP pelvis, an AP hip, and a cross table lateral. You can get away with a frog lateral, but in general, having a cross table is kind of the standard, at least for what we use. And then, okay, that's what I was looking for. It says another recommended view is full-length femur x-rays or traction internal rotation view as well. So by definition, if you're doing surgery on a bone, which is, in these femur fractures, generally you would recommend surgery, which we'll get into maybe another day, that discussion, but you want to be able to see the whole bone of whatever bone you're going to be working on. And the reason is you can't tell if this person has a a tumor in their distal femur. You can't tell if they have another fracture in their distal femur. You can't tell if they have a total knee with a huge stem that goes up their distal femur proximally that's going to block your, construct of what you had planned on using. So this can delay cases, and if you know this, if you take this to heart and memorize it, and you're always thinking like, okay, we might have to do surgery on this. We need to make sure we see this whole bone. So I need to get a full femur X-ray series every time I have a hip fracture. You just burn that into your brain. So, and then internal rotation traction view, that's where you can't, if you have a hard time delineating what type of fracture lines you have, where they exit, where they come from, what type of, is it a femoral neck, is it an intertroch? That's where escalating to literally going down to the ED and pulling on someone's leg with internal rotation while you shoot an X-ray, it can be actually really helpful to help give you that information, which can affect how you fix their fracture. It can be a little bit painful, so you have to make sure they have pain meds and kind of coach them through it.
So treatment for these fractures is pretty important. Surgery within 48 hours decreases the 1-year mortality rate. And so that's why we really shoot to get these patients urgently treated. And so there's also a 1/3 rule where about a third of people regain function, a third lose 1 level of independence, and then there's the 1/3 mortality rate. So non-operative treatment is rarely indicated, but we may consider it for some of our non-ambulatory patients or those with higher perioperative mortality risk, which is very that's something we can consider with our demographic and who's it impacting. And then surgical treatment is based on the fracture pattern and the stability of that and everything we just went over. So intramedullary nailing, which we'll get into very soon, is indicated for fractures involving the lateral femoral wall or other unstable fracture types. So we can basically say if it's unstable, then maybe we should start to think intramedullary nailing. And then the sliding hip screw or the short femur nail is usually indicated for the fracture patterns with an intact lateral wall. So we can equate that to more of our stable fracture patterns.
So another way to put that is for stable intertrochs, you can do short nails or sliding hip screws. And then everything else long nail. So
yeah, so like Drew said, sliding hip screw we're going to use for our stable patterns. Some of the advantages is that are that they allow for interfragmentary compression, and they are much lower cost than the intramedullary nailing. But some of the disadvantages is the fact that we do use an open technique, so there's increased blood loss, and that's something we may want to keep in mind. And then for our unstable patterns, we have the intramedullary nailing. And so a longer nail may be used for the fracture types that have the subtrochanteric extension or femoral shaft fractures, but also we can use the short intramedullary nail for the pertrochanteric fractures without a distal extension.
if you use the term pertrochanteric or peritroch, generally you don't want to use short nails in those types of pertroch fractures. So you probably read that somewhere. There's at least case series of showing where intermediate nails or short nails can toggle with these kind of subtle unstable intertrochs. And when you're getting into the territory of pertroch or slight extension, but not like more unstable than just a pure standard stable intertroch, then you have to be pretty wary of jumping to the short option or an intermediate option.
I see.
Yeah. So a firm takeaway is if it's a stable intertroch, then sliding hip screw or short nail. If it's an unstable intertroch with those 4 patterns we talked about, then I would, in your mind, just avoid short or intermediate, go straight to the long nail.
Did anyone have any questions before we go on to trying to read these images?
Hey, I can give it a shot. So, AP of a left hip, and you can see obvious fracture line going from the greater trochanter to just inferior to the lesser trochanter. So I would call it a intertrochanteric fracture with minimal displacement.
Yep. So
Nice.
if I would say that's correct. The one thing to work on that takes a ton of practice, and it took me a while, is to immediately, if you know the answer, you just say it in the most concise, clear way you possibly can. So when an attending says, "Read this for me," you would say, "This is an AP of a left hip in a skeletally mature individual showing a comminuted left intertroch fracture." But everything you said was correct. But you just say what's the most obvious thing, in the shortest way possible, the most accurate way possible, without getting too much in the weeds. I think that's the biggest way to distinguish more veteran students from newer students. Because if I give I think when I first started describing fractures, I would literally be like, okay, well, there's this line, and then there's this piece here, and then there, and they may ask you about that, but you want to just say the answer and then kind of hold back all these details that you might know until someone starts asking you about the details. So in going off of that, would you call this a stable or unstable intertroch?
Probably unstable, given the comminution.
What's specific about it?
Well,
what category of unstable would it fall into, do you think?
I suppose it will involve the calcar.
Yep, exactly. So I know you guys can't see my arrow, but outlining it, you can see the lesser trochanter here, and then it's kind of like this whole fragment or base of the trochanter is involved. So you have to be thinking, okay, posterior medial calcar. And truthfully, I've seen some attendings just be like, look at a intertroch like this and be like, whatever, we're going to short nail it anyways. As long as you understand that there's potential for this to be an act more unstable than a standard intertroch, perfect. Like the trauma attendings that are doing this, they do it all the time. They're very experienced. They have their reasons. But I'd say, again, the safe thing to think about is what, if it's not a stable standard intertroch, what category of unstable does it fall into? And I would agree, this looks like posterior medial calcar involvement. Perfect.
All right, and this is the last image. Does anyone want to try and describe what they see here?
Is Bill here?
I am. I'm still thinking through it.
Oh, okay.
I'll give it a shot.
Sure.
So it's an AP pelvis of the right hip in a skeletally mature individual with a intertrochanteric fracture that's comminuted, that is likely unstable.
Perfect. Did you say AP pelvis or AP hip?
I said AP pelvis.
So
I should revise that to AP hip.
Yep, exactly. It's an AP hip, and the main thing is just whatever the image or the X-ray image is centered on. So if it's centered on the pelvis. If it's centered on the hip. It took me a while to be like, okay, well, like, where do they know to put these plates when they're lining them up and this or that? It's like, okay, well, in the specific part of the series, whatever image they're getting, the point is to get the main part of the image centered on the plate. So I would totally agree. Or Marquisha, I don't want to steal your feedback. If you had some things you wanted to add, so interrupt me if you do. But I would.
No.
Would this also include the calcar?
Yep. So I would say, to me, this looks like posterior medial calcar involvement as well. And again, it's because that fracture line includes more than just the distal or more medial aspect of the lesser troch. It's more like a chunky piece. It's the root. It's that really firm structure or large structure of bone that runs up the posterior medial aspect of the proximal femur. The other thing too is that, these fractures don't always like fit into perfect categories. So you could look at this and say, well, the lateral wall looks pretty thin too. So it's a little bit hard to tell where your innominate tubercle is to measure off of 3 centimeters distal and then up 135 degrees. But if we actually measured it, I would say this looks like a thin lateral wall, or at least getting there. So like kind of two unstable features in my mind for this intertroch. So Bill, what type of what would you want to do to fix it?
I don't know.
So really, let's go back to the options here. Would you want to use a sliding hip screw on that, which is the left image?
Probably not. Probably not.
Oh, yep, 100% not. Your construct would fail. These,
Yep.
One day, hopefully, we do a lab or something where you can actually see how these work. But the leg screw kind of sits in this. There's probably an engineering and technical term for that part, but it literally slides into a sleeve and it keeps going. None of that aspect between the screw or the leg part of that screw that goes into the femoral head and the more distal sleeve is like firmly connected. It's sliding freely. So if it's really unstable, that construct is definitely not going to hold a unstable intertroch. A short nail, sometimes people try to push its limits as far as stability, at least with Synthes. The distal locking screw can toggle a little bit. So the safest thing in an unstable intertroch is to go for a long femur nail. And it literally just looks like this short nail only extended all the way to the distal aspect of the femur.
So you're doing an intramedullary nail with a long nail specifically because it's so unstable.
Yeah, let me show you so here's an example where you have that rod, people call it a rod, people call it a nail. The nail goes all the way from the proximal aspect of your femur through the greater troch down through the shaft and ends just proximal to your kind of notch at your distal femur. You get a lot more stability from having a long femur nail than you would a short nail. And then this is an example of an intermediate where you still have the screw, like distal screw that looks like it would be in place for a short nail. It just has a little bit of an extension on it.
Drew, why do people, like you said, try to use the short nails preferably over the longer nails? If the longer nails universally provide more stability, like what's the advantage there?
It's a good question. Some trauma attendings literally just say, I'm going to do a long nail no matter what every single time. But the advantage of the short nail is that I would say it's faster. I think that's why people like it and why they go for the short nail over the long nail. And the reason is that if you probably haven't seen one, but if you look it up, when you put these nails in, they're attached to this carbon fiber jig. and so they're screwed onto the jig, and you can just slide the jig into the have the nail slide into the femur while you're holding onto the jig, and the jig lets you put a screw right where you need to place that distal locking screw. So it already lines it up for you. You don't have to use x-ray to get a perfect alignment to where you're doing it freehand like you would in a distal or a long femur nail. So in a long femur nail, you have to bring in x-ray, get what they call perfect circles to make sure you're lining up your x-ray with the opening in the distal aspect of the nail to be able to drill it and then put a screw through that distal aspect of the nail. So I think speed is the main thing as far as why people like the short nail.
That makes sense. So essentially, it's faster and less complex.
Yeah, faster. It'd be interesting to hear. Everyone has different opinions about everything, but another thing with the short nail, it technically creates like a stress riser. So if that patient were to have another fall, the whole distal aspect, distal to that short nail, is unprotected. So if you have a really stiff nail in the proximal part of your femur, you fall and have a huge force on the femur, it's more likely to break right at the tip of that nail. Whereas if that patient were to fall and they had a long nail in that femur, maybe they wouldn't have gotten another fracture at all. If that makes sense.
Yeah, it does. Thank you.
Yeah. Great question.
Would you say the last x-ray we saw had any subtroch extension?
So this is a good question. In my mind, that fragment looks to me just like a large calcar piece. But I don't think anyone would fault you from saying maybe there's a little bit of subtrochanteric extension. When you see a lot of these and you have your lesser trochanter connected to a sliver and kind of the root of it with a sliver just breaks off, that's usually the calcar piece. So in my mind, I would lean more towards calling that a calcar fragment rather than subtrochanteric extension. But that's a good question. You might ask one of my peers or another attending, and they would say, "No, Drew, you don't know what you're talking about." But I think that's why orthopedics is fun, because there's a lot of different ways to do things, a lot of different opinions. Marquisha, nice job. Thank you for going through that.
Yeah, of course, it was fun.
Really
Always.
quick recap. You have your stable intertrochs that have the line from the greater troch to lesser troch, and then you have your 4 unstable types: posterior medial calcar involvement, reverse obliquity, thin lateral wall, and then subtroch extension. So if you can just memorize those and rattle them off when someone asks you, like when you're on a rotation, you'll be way ahead of the game. You'll be even further ahead if you can actually recognize them. It's one thing to say them, but to look at an x-ray and say that is that, and that is why it's unstable, and you can put a name to it, that will get you way ahead from definitely where I was at when I first was doing my away rotations. Oh, I don't think I've written the hip fracture portion of the kind of x-ray reading course, or the Atlas course. That's on my to-do list. But my goal is to just have that be very clear of like what each intertroch type looks like, so that you can kind of burn it into your brain and just be able to recall and say, yeah, that is for sure. That is a posterior medial calcar involvement. That's an unstable intertroch. I'd put a long nail in that. One day, I think it'd be cool to do, have that in our course, but also to make a bunch of like Anki flashcards, just so it becomes like a repetition thing. I'm an Anki fan, not as much as some of you guys probably, but I think it's a really, really helpful tool. So that's also on my to-do list.
I like Anki too.
Whoever invented Anki is like a genius. Well, you guys have a happy holiday. I don't want to keep you too much longer. Let me make sure. Doyle says, great job, Marquisha. I agree. Thank you very much for doing this.
Thanks, Doyle. Andrew.
If anyone has any questions, just throw them in the public chat channel, and one of us will get to them. Next week, I'm on operative trauma call, so I may or may not be around, but I'm not planning on doing any official meeting next week, just because it's too risky to commit. Especially all you guys out there, doing things you shouldn't, drinking too heavily after New Year's. So don't do that. Well, thanks again, guys. You all have a good night. Avoid COVID. Heal up from COVID if you have COVID.
Good night, everybody.
Thanks, guys. See ya.
See ya.